Hi, everyone. Thanks for being here today. This is our final webinar this year. We'll be back on March, around mid-March. I just forgot the day, uh, but we'll come back next year. And just to tell you that today we released the photographs from the last GFAM meeting. They are in our website, gfam.com.br. Please go there and find your photos and enjoy because we have a lot of photographs there. Today, we have the pleasure to have here Maria Fernandes Rosales-Rueda. She's an assistant professor at the Department of Economics at the University of Delaware. She's also a faculty research fellow at the NBER, Families and Children Program. Her research interests lie at the intersection of human capital, health, and development economics. Thank you so much, Maria Fernanda, for being here today.
Thank you. Thank you so much, and thank you for your patience through
No,
for
no.
waiting while I was navigating these internet issues. But yeah, I'm very happy to present this piece of my research. So in this paper, it's co-authored by this all-female economist here in across different places here in the US. And in this paper, we study one of the war on poverty programs here in the US. So the war on poverty programs were rolled out around the 1970s to fight poverty here in the US. And one of those programs is this supplemental food nutrition program. And in this paper, we examine what is the effect of the rollout of these programs on birth outcomes using some new rollout information that we found in the National Archives. And so, as a motivation, policymakers and researchers are always concerned about socioeconomic disparities in health outcomes across the world, but particularly in the US. One of those markers of socioeconomic disadvantage is health. So there is we are here concerned that there are important and sizable racial disparities in health that starts very early in infancy, and they manifest across the life cycle and persist over time. And just to illustrate a marker of infant health, here in this figure, we have the incidence of low birth weight. Low birth weight is defined as having a birth weight less than 2,500 grams. And here we plot the incidence for black mothers and on purple, and on gray the incidence of low birth weight for white mothers. So we see that there are sizable gaps in this marker of infant health. And yeah, this is our study period, and that I will explain later on. And these gaps, yeah, we have advanced in reducing them, but they are still persistent. A natural question is like, okay, why do we care about health at birth? So there is evidence across multiple disciplines from economics, but also from sociology, epidemiology, and biology, that infant health is an important determinant of later human capital outcomes, including schooling, labor market outcomes, and adult health outcomes and mortality. And across the world, there are different type of social programs to address health disparities across socioeconomic disadvantaged groups. I came across one paper by Rudy Rocha, Rodrigo Suarez, and Sonia Balotra about one program in Brazil that I got really interested. I want to know more. Maybe at the end I will ask you guys about the Programa de Saudade de Familia.
Mm-hmm.
So in this case, in the US, there are several public policies that try to address these gaps in socioeconomic outcomes, and these type of policies are both demand side policies as well as supply side policies. So on the demand side, we have policies like cash transfers. Here in the US is the earned income tax credit. Also, health insurance program subsidized health insurance. In this case, Medicaid is the program for families and children from low socioeconomic status. On the supply side, also in another paper with my co-authors, we study the effects of the effect of the introduction of the community health centers here across the US. And on the demand side, there are two important nutrition and food policies here in the US. Food stamps or SNAP is it's a policy that aim to provide access to food to low-income families in general, but WIC is particularly for women, infant, and children, for pregnant women and children age less than 5. So WIC, the Women, Infant, and Children Supplemental Nutrition Program, is the focus of this paper. There is there are several pieces of evidence about the impacts of all of these different type of social interventions. And in the particular case of WIC, I will discuss very briefly that we built upon a previous study, but yeah, but that is like the only study that have examined the effects of WIC on birth outcomes. And we extend their work by augmenting and extending the rollout with new sources of information that we found in the National Archives. So in this paper, we provide new evidence about the effect of WIC on infant health, and particularly we found very interesting effects by race, comparing white mothers versus Black mothers. So in this paper, we ask whether access to nutritious food during pregnancy impacts infant health or health at birth, and whether do these effects vary by race. And we are going to use a difference in difference approach that is going to leverage variation across counties and across years on access to WIC clinics between 1974 and 1981. And just as a quick preview of the findings, we found that WIC indeed reduced the incidence of low birth weight with larger effects for Black babies relative to white babies. And we also found effects on other cuts of the birth weight distribution, particularly on the left. So not only on the 2,500 grams, but also other cuts. So the effects we have effects on reducing the likelihood of different probabilities of very low birth weight. Uh, so in this paper, we contribute not only by adding new evidence about the effect of this program, but also we expand the previous rollout data with new sources, with detailed sources from the National Archives. We also use new difference in difference methodologies, and we consider the effects by race, and we are currently exploring why do we see larger effects on Black babies versus white babies. So let me give you a little bit of background about the Women, Infant, and Children Supplemental Food Program. So this intervention started, as I was saying, this was part of the War on Poverty programs. It was one of the last set of programs created by President Johnson here in the US, and it started as a pilot trial in 1972. But the first clinic part of this program opens in January 1974 in Pineville, Kentucky. The way the program works is that the federal government give some grants to the states. So the states uh, apply to these grants, and those grants are administered by nonprofits and clinics, and they require to have medical personnel in the clinics uh, as part of the program. So, uh, why this program has the potential to influence health at birth? So, particularly because this program give access to nutritious foods and other services. So it gives pregnant women access to this healthy food via vouchers, direct delivery, or pickup. And it also offers nutrition, education, and counseling and other referrals uh, to other services. So this is a targeted program. This program target uh, pregnant women, postpartum women, and children less than age 5. When the program started in the 70s, the way eligibility was assessed was whether the pregnant mother was eligible or was using free or sliding scale healthcare. Later on, or the way the program operates now, is using an income eligibility threshold. So important for our study, as I mentioned before, we is going to fill a gap in nutrition for this low-income mother. So it provides a really sizable share of food and nutrients requirements to illustrate that, to get a lot of information from this program because it's in the 70s. There are not many like electronic records. We had to read reports, Congress hearings, and in one of those reports, just to learn about the type of the program, we saw that, for example, for the case of the WIC benefits in California in 1976, the package of nutritious foods, you could think about like this is going to be eggs, milk, vitamins, um, fortified iron cereal, so eggs. So yeah, this package is going to cover around 60 to 100% of the required dietary uh, calories, and like the required dietary allowances for protein, calcium, iron, vitamin C, and vitamin A, and it's around 25% of the calories. All of those nutrients have been uh, found important for the healthy development of a pregnancy. In terms of the cost, it's estimated that the value of the food package or the average voucher for a pregnant woman in Oakland, California, was around 25.25 in 1975. And also another piece of context is that back in the 70s, many states didn't offer pregnant women access to Medicaid or prenatal care through Medicaid. So, yeah, this program was also providing nutritious education. So, many of the places where the program uh, was rolled out were medically underserved. So, yeah, as I mentioned before, there is a prior seminal paper to us by Hilary Hoynes, Marianne Page, and Anne Stevens that examine what is the effect of the rollout of WIC, and they do find effects on birth weight by around 3 grams, and they didn't find effects by race. They found effects that are larger for mothers with lower education, but they didn't find sizable impacts on low birth weight. And WIC has been a program that has been studied uh, significantly, and there are these couple of review papers, and most of the evidence concentrates on the contemporaneous WIC program, and a lot of that evidence is observational. There is some quasi-experimental evidence, but for particular states like Florida, Texas, and North Carolina. So, yeah, one of our contributions, as I mentioned before, is constructing a better or improving the previous measure of week rollout. That is going to be the introduction of weeks across county over years. So, yeah, Hillary and co-authors, they generously like share their data. We also enter by like we also digitize their sources of data. So their sources of data were congressional reports, congressional hearings and reports. So whenever you see HPS, we are referring to that study. So yeah, we re-enter their data that are these reports that contains a list of of local agencies operating week programs in different counties. They have information on fiscal year 74, fiscal year 75. Then for fiscal year 78, their sources only have information for 13 states. And then the last piece of information from that prior study is in fiscal year 79. And yeah, we were visiting the National Archives here in the US, and we discovered that the states needed to provide with weak state plans to document the program operation. And in those weak state plans that we found in NARA, the and I'm going to show you an example in the next slide. States give information on the list of local agencies, but very importantly, it gives us information about which counties were served by these agencies. So we scan those state plans, and they started in fiscal year 78 for 7 states, and they expanded to all states in fiscal year 79. And we process them to fiscal year 88. We stopped there in fiscal year 81 for this paper. It's also a natural point to stop because in 1981, when President Reagan, in his presidency, they cut funding to WIC. So yeah, the program is more homogeneous between 74 and 80. We also, yeah, to be able to back up treatment on the treated effects, we need some information about take-up and participation. And we found some sources, so we digitized them as well in fiscal year 81 and by race in fiscal year 86. And yeah, this is an example of those state plans. This is an example from the Pennsylvania state plan in fiscal year 89. So states provided information sometimes using maps like the one we have here in panel A. So here we have the counties and we have like different legends or different flags. So yeah, we know counties where WIC was in full operations. We also know counties where WIC, uh, that counties that may have submitted an application, but they do not have WIC, or that are currently preparing an application. And then we also have for several, like the way states present the information is not consistent across states and across years. So the digitization process took a lot of time. And yeah, another source of information that we found in state plans, and we usually cross-check them, is, for example, here a list of WIC agencies and the counties that they are serving. So here we have the location of that agency, but that agency is not only serving sometimes the county where they are located, but sometimes they are serving other counties nearby. So we digitize the counties served, and that is the rollout information that we are going to be exploiting. And yeah, just as a note, yeah, it's this map was not colored by us, it was colored by someone in 1978. So here I want to provide you with an illustration of the time variation that we are going to be exploiting. So here we have the number of counties that adopted WIC in a given year from 1974 through 1981. And so in 1974, 359 counties rolled out this program. And then, we see an increase by 1980, 2,381 counties had introduced the program. This is out of around 3,000 counties, and this is already covering 80% of the birds. We didn't, or we exclude the state of Virginia. The state of Virginia here is a little bit problematic because geographic units are not counties there. Sometimes there is a combination of counties and cities, and we also exclude Alaska and Hawaii. And I mentioned that these state plans were introduced in fiscal year 78, but some of these plans have retrospective information uh, from like giving information about 76 and 77. So we are able to gather information from like detailed information from these prior years. So to give a sense about like how we are expanding the rollout information versus our predecessor colleagues, Hoynes and co-authors. So here in black, these are our counties, and in blue are the counties part of the data from HPS. And yeah, we particularly in 78, that's when the state plans start, we gain significant information from several counties that were not part of their data. Yeah, their data had some holes that we are able to fill. And here in this map, I wanted to illustrate the geographic variation as well as the time variation. Yeah, the legend is a little bit small, but let me walk you through. So in yellow, we have the counties that introduced WIC in 1974. Then in light green are the counties that introduced WIC in 1975. Then as we get darker are the counties that introduced WIC later on up to 1981. And yeah, so an important takeaway from this slide is that yeah, there is variation across counties on the introduction of WIC, and even within a state, like for example, this is California or here is Florida. Even within a state, there is going to be variation that we use in the robustness checks to include a state by year fixed effects. So yeah, this is the geographic and time variation that we are going to exploit in our difference in difference. So now let me share about the different pieces of data that we use in this study. So yeah, an important the core piece of data here is the WIC rollout data that is gonna come from the state plans, national archive sources, from digitizing again the Hoynes and co-author sources, as well as additional reports and hearings that we found. So yeah, that using that information of the rollout give us when in which year a county started to operate a WIC program. We match that WIC rollout data, so we are going to use the month and year that WIC was introduced, and we are going to match that with viral statistics that is going to give us information about health at birth. So that viral statistics have information about the county of birth as well as the month and year of birth and gestational age. So yeah, one outcomes that we examine corresponds to birth weight, low birth weight, small for gestational age, large for gestational age, and different cutoff of the birth weight distribution. We also, to do some compositional analysis, we use population data from the seers, and also to try to understand the program, like the determinants of program rollout. We are going to use 1970 county characteristics, pre pre-program characteristics, as well as yeah, we estimate at several specifications to make sure our effects are robust. So we also, in some of those specifications, we control for time varying county characteristics like cash transfers uh, or Medicaid that was also being underdeveloped in that period. So to be able to to control for Medicaid, we use the state by year by race. AFDC participation is participation in a welfare program that determines participation in Medicaid, that is the health insurance program.
Maria Fernanda,
Yes, of course. Mhm.
what's SEER?
Ah, SEER is it's the Center of Economic. It's a data set that has demographic information of like population, like the size of the population at different ages, 0 to 1, and all the ages.
Okay, thanks.
Thank you. Thanks. So now let me walk you through our empirical strategy. So here you find this is the static difference in difference. So yeah, we do have individual birth records, but estimating these models can take a lot of time in the individual data. We do them in the robustness checks, but yet for computational ease, a lot of researchers, what we do is we collapse the data by cells. In this case, cells are defined by race, county of birth, and the month and year of the start of the second trimester. So as I think I mentioned before, that in the parallel statistics, we have the month and year of birth, and then we have the gestational age. And with that information, we can back up at what point in the pregnancy the second trimester started, like the month and year. And we use that to allocate exposure to week, because usually around the second trimester is when mothers are aware of their pregnancy and they enroll in the program. But we did some robustness checks using the third trimester, using the birth month and year of birth. So, yeah, so here we have the outcome. Let's say the average birth weight for a cell defines like blacks in the county of New York City in February 1975. So then this dummy that is going to capture our geographic, county, and time variation, this is going to be an indicator equals to 1 if those birds born in New York, those birds that started their second trimester in January 1975, whether they were exposed to week depending on their month and year and their county. And so this variable C underscore CT corresponds to county time varying control. So yeah, we worry that, and I will explain in one slide, we will discuss the identification assumptions of difference in difference. But yeah, this program is not random. So yeah, we worry about some endogeneity of program placement, so that we worry that there may be some county characteristics that could confound the effect of weak. So I will explain in a few slides that in our preferred specification, the way we are going to control by these county characteristics is by using a propensity score reweighting approach that is going to make the counties that are treated and untreated as similar as possible based on pre-programmed characteristics. But then we also did different checks where we control directly by some of these variables. We also include county and month by year of the start of the second trimester fixed effects to capture unobservable circumstances that are time invariant at the county level and national changes happening at different mountain years. We cluster the standard errors at the county level because that's the level of the geographic variation. And I'm going to present visually event study. So we also estimate a dynamic version, an event study version of this equation to try to examine some dynamics. So let's discuss some of the identification assumptions underlying the difference in difference strategy. So as I just mentioned, yeah, one assumption is that the there is an exogeneity of program placement, or that yeah, the program rollout was quasi random. So yeah, the question or the issue here is whether the timing of week rollout is exogenous after conditioning by county and by mountain year fixed effects and some covariates. So to test that, what researchers usually do is to try to see if there are some counties with some characteristics that tend to receive the program earlier versus later. What we did is an analysis that examines as the dependent variable the mountain year when week was rolled out, and as explanatory variables, we include a lot of pre-program, pre-1974 county characteristics like urbanicity, poverty, population, infant mortality, uh, public transfers per capita. So yeah, we did that test to see whether these like observable characteristics could predict a weak rollout. And yeah, we found that the R square was relatively low, was less than zero point 0.3. So a lot of variation remains unexplained. But we do see some evidence that counties that were more urban and with high poverty, they tend to introduce weak earlier. So because we are concerned that there could be some potential observables explaining or associated with weak rollout, how we're going to address that issue is we are going to create propensity score weights. So we are going to estimate a probability of having weak by 1980 against these pre-programmed characteristics and use that propensity to have weak to reweight the ever treated and never treated counties. Yet the second important assumption is the parallel trends assumption. So yeah, under this assumption, we are assuming that in the absence of weak program, counties that did not receive weak, our never treated counties, and our treated counties would have behaved with the same trends in the absence of the program. So to be able to test that, we are going to use event studies specifications, and also we did perform some of the more recent approach like the ROD testing for parallel trends. Another important assumption is that for like the standard approach to estimate difference in difference used to be or is using two-way fixed effects, but recent developments in the difference in difference literature have documented that two-way fixed effects is unbiased only in the scenario of homogeneous treatment effects, where the effects are constant. So yeah, that's very unlikely to happen because we have this staggered rollout. We have some counties that receive the program in 74, others in 75, and so on. And it may be that the program, the effects of week is not gonna be the same for all these different counties that adopted in a given year. So it's very likely that there is very likely that treatment effects are heterogeneous. And first, we test if there is some evidence of of heterogeneity, we did find, so we use the test proposed by Teches Martin and Holfoyal. And the way to address that, we are going to use the difference in difference estimator by Son and Abraham. So yeah, in the Son and Abraham approach, we are going to use the never treated counties as the comparison group for our ever treated counties. But in our case, our rollout information ends in 1980. So in our case, our never treated counties are counties that didn't adopt WIC by 1980. Those are around 500 counties. So, and then, as I mentioned before, because we are worried that counties that adopted the program could be different than counties that didn't adopt it by 1980, we are going to use this propensity score reweighting approach where we estimate a propensity, a likelihood of having weak by 1980 against a lot of county pre-program, pre-1974 characteristics. We are going to predict that propensity and we are going to use that propensity to reweight the untreated counties. And this has the advantage of making the never treated or the comparison group as similar as possible based on observables to the treated counties. This is an approach very similar in nature to the Callaway and Shaw approach. So yeah, we are going to reweight the cells. So the untreated counties, we are going to reweight them like, yeah, all of the regressions are weighted by the number of birds because yeah, our cells are at the month and year. In some counties are bigger, they may have more birds than others, so we want to take that into account. So we weight everything by the number of birds, but then to be able to make the treated and untreated counties as similar as possible, we are going to reweight the untreated counties by p hat over y minus p hat. P hat is that probability of having weak, the propensity score. So now let's go to the results. Let me first show you some static diffing diffs. So here on panel A, we have the effects for low birth weight, and on panel B, we have the effects for average birth weight in grams. So remember that low birth weight is defined as having a weight less than 2,500 grams. So we see here blacks in purple and whites in gray. And here we see that a sizable and statistically significant decline in the probability of low birth weight of almost 0.4 percentage point. To make it to make it easy to digest, we divide this relative to the mean, like the average probability of low birth weight. These effects are around 3% of the mean. In contrast, there is a decline on that likelihood of low birth weight for whites, but it's not statistically significant. And it's around 0.2% relative to the mean. When we look at birth weight in grams, we see an increase in birth weight for blacks of around 13 grams and of around 4.9 grams for whites. Here are these effects as a percent of the mean. And yeah, these are intent to treat effects. So here we are treating like all the birds in the county are intended to be treated. But we know that this program targets low-income families. So we wanna try to rescale that intent to treat to a treatment on the treated to see how large are these effects if we take into account that this program tends to benefit low-income mothers. So yeah, to try to back up the treatment on the treated, ideally we would have information about participation rates by race from 74 to 81, but that data about weak participation across counties, across years, and by race doesn't exist. So the best, like the only information that we have found so far about weak participation by race is coming from from a report. Here we have that 36% of Black babies participated versus 15. And we are going to use those rates of participations to scale that ITT. And here we see that the treatment on the treated effects are larger for Black babies. So when we rescale, the treatment on the treated effects are minus 1.02 percentage points. That is around minus 8% of the control mean. And for whites is 0.3 percentage points. This is around 5% of the mean. And these effects are comparable to the effects of other uh, interventions here in the US. So now let me show you some dynamics. So yeah, let me walk you through how these figures are structured. So here on panel A, we have Black mothers for low birth weight because that's our main outcome. And here we have white mothers. And here we are presenting three specifications just because we want to be able to convey as much information as possible with one graph. So in blue is our preferred specification that is going to reweight the counties using the propensity score weights. And yeah, here, so here we omit minus one. And here in the horizontal axis, we have the periods since the event. So here is minus 1, 0, 1 year after, 2 years, and 3 years. And we been 4 plus, and then here we have minus 2, minus 3, minus 4, minus 5, and we been those distant lags and least distant leads. So yeah, in blue, it's our preferred specification, the propensity or the reweighted estimators. But then there are two main concerns when executing these event studies. One is that because we are conducting our analysis and at the month and year, because we want to use all of our information, it is very possible that some counties may not have Black birds in a given month and year of the second trimester, and only white babies. So there may be some composition of counties that could be contaminating our results. So to address that, we only use in red the sample, a balanced sample of counties, meaning a set of counties that we can observe in all the month and years. That is going to be the red specification. And then in green, that is a specification where that address usual concerns that there may be some also composition of counties on distant lads and distant leads, meaning that maybe here in plus two, we don't have all the counties or the same counties that we have in plus three or minus three and minus four. So to do that, we also use a balanced set of counties that we observe across all of the relative time periods. So, and here, one may take away is that, yeah, we see that there is not really sizable, like there is really not much evidence about the presence of pretrends. And then we see a gradual decline in the probability of low birth weight. It starts showing up 2 or 3 years after. And we also see that our results are not really driven by those concerns that we had. Our those specifications or those samples have similar effects. For whites, we saw there could be some potential presence of pretrends. So yeah, we have to be cautious. So we also explored the impact of the women, infant, and children nutrition program on other birth outcomes that are collected in the viral statistics. For example, here we have very low birth weight, that is the probability of having a weight less than 1500 grams, we see a significant decline for blacks, not statistically significant for whites. Also, if we take into account the gestational age and we calculate small for gestational age, that is a proxy of intrauterine growth restriction that is related to nutrition, we also see a decline in the probability of small for gestational age that is not uh, significant for whites. We also saw an increase in high birth weight. We define high birth weight here as having a weight higher than 40 100 grams. And we also saw an increase in large for gestational age for blacks. So now we start to explore like why are we seeing or why did we see larger effects on low birth weight for blacks versus whites. So one way that we try to address that is by let's look at effects at different points of the birth weight distribution. So in panel A, we estimate the effect of week at different codes. So the effect of week on the probability of having birth weight below this threshold, 1500, below 2000, below 25, so below a given threshold. And we do see that the effects are larger and even like the confidence intervals do not overlap, the effects, the point estimates are larger at different points on the left side of the birth weight distribution. In panel B, because we know, and I'm going to show you a figure in a few, we know that black babies, they tend to have worse baseline outcomes, meaning that also as we saw at the beginning, the probability of low birth weight was higher for blacks than for whites. So in panel B, we divide those estimated coefficients by the mean for that race to take into account those baseline differences. But even when we do that, we do see sizable and larger effects for, for Black mothers. So what this analysis tell us is that the differences by race are not one explanation is the differences in baseline, but it's not completely driven by those differences at baseline means for Black birds versus white. Again, because when we divide by the mean, there are still some differences by race. So yeah, now we keep exploring. Okay, so what are other potential explanations that can explain that we find larger effects for black mothers in low birth weight than for white mothers? So one explanation is that eligibility, participation, and take up for week is higher for black mothers than for white mothers. So yeah, to do that, panel A, we calculate some numbers about eligibility, and for panel B, those are the numbers that we use in the re-escalation of the ITT to get the treatment on the treated. This is the participation by rate, the only number that we found in 1986. But yeah, to be able to kind of like proxy eligibility, we went to the Consumer Population Survey, the CPS, and we tried to determine eligibility by looking at family income under the 185% of the federal poverty line, or if that the family of that child was participating in welfare programs. So we see that both eligibility and participation are higher for Black mothers, and that could be one explanation who underline these larger effects for Blacks. Another explanation is that, as I mentioned before, is the idea that the baseline birth weight distribution, like the baseline outcomes for Blacks, are worse than for whites. So by having a lower baseline, there is more room to influence black versus whites because the blacks were worse off. So yeah, that is another potential explanation. Here we have the distribution of birth weight for black babies in purple and in white for white mothers. And we see that yeah, there are more black babies on the left cutoffs of the birth weight distribution. So yeah, that's another potential explanation. Then we did some other analysis that is trying to look at whether we could see effect, like we could see that individual risk factors or place-based risk factors are affecting more blacks than whites, and that could explain the, the different effects. And let me explain what we did. So yeah, when we are thinking about individual risk factors, those are individual factors like teenage pregnancy. Those have been documented to influence health at birth, marital status, and education. Um, and before like to do that, we also because yeah, when we examine effects of policies in pregnancy, we wonder about fertility responses. But yeah, we didn't found fertility like any fertility responses or character or differences in the characteristics of mothers getting birth. So then after that, we examine whether for Black mothers in panel A versus white mothers in panel B, if the effects were different by teenage motherhood, marital status, education, or birth order. So here in Black, we have our preferred specification. And then, for example, here in purple, we have the effects for teen mothers versus non-teen, single versus married. But as you see, the confidence intervals overlap, and we do not see any conclusive evidence. Yeah, we do see, for example, that the effects tend to be larger for single mothers among the Black mothers or for lower educated, but it's not really statistically different. So then we decided to, okay, maybe the places where Black babies or Black mothers live versus the places where white mothers live can explain that the program may have larger effects for Blacks than for whites. So yeah, we start to examine a lot of place-based factors. The first factor related to that is the program size in a county. So whether the county had a big or a larger weak program versus a smaller program. So to not use, we are not going to use the actual take up because that could be endogenous. So what we did is we have take up by county in 1981, and we predict take up and we divide the counties by above the median predicted take up and below the median predicted take up. And yeah, we see that the effects are larger for Black mothers in places where the program was larger, but again, not conclusive because the confidence intervals overlap. Then we examine other socioeconomic conditions of the counties, for example, poverty, urbanicity, and whether the county had like some medical disadvantage, like poor baseline birth outcomes. But like here we have poverty, urbanicity, but it's really not conclusive. Then the third set of place-based factors is medical need. Maybe like we say, okay, maybe the effects could be different in counties that have a better supply of hospitals or counties where Medicaid was larger, and we try to do that, and we do not like we see the effects for Black mothers being larger in counties that had more hospitals, but it's really not conclusive. And then the last set of place-based factors is, yeah, there is some evidence about the role of structural racism here in the US. So to be able to, and like, yeah, the Black, like the segregation of Black in the south. So we examine the effects by counties in the, or sorry, by states in the south, all Confederacy versus non-South. Another measure of structural racism is whether in a state there is a high share of black birds that are not born in hospitals. And we do see here that, yeah, the effects tend to be larger for the South, where there is more racism, or in the or states where blacks babies are not born in hospitals. So yeah, there was a room for improvement in those places, but again, not really conclusive. The confidence intervals overlap.
Can I ask you something?
Of course, yeah.
Uh, in these places, do you know the if the inequality is higher on these states
In
or
these,
in these counties?
yeah. So we know, like, yeah, in these, in the South states and in these states, yeah, those are states with racial, like high racial inequality. Yeah, but that's a good point. So yeah, you were like, that's another part of the place-based factors. So maybe we could also try to think about a proxy of inequality. That's a good idea. Because yeah, here is race, but we could find maybe better proxies because these are at the state level. Maybe there is some proxy of inequality at the county level. That would be better. Thank you. Yeah, so yeah, we did the several analyses so far, and yeah, the differential effects by race, yeah, those larger effects that we found uh, for low birth weight for blacks are not really explained by individual risk factors or place-based risk factors, but I think, yeah, this like a proxy of inequality could be a good idea to also add to our analysis. So far, our our argument is that the effects are larger for blacks, probably due to differences by race in eligibility. Blacks have a higher eligibility, higher participation, and also because they have worse base outcomes that can, like, that gives more room for improvement, and there may be a role for structural factors. Then we have done a lot of robustness checks. We test for parallel trends using the ROD testing approach. We did several specifications. We assign week according to the birth year, the year of the third trimester, the month. We use uh, just like alternative use of gestational age. Also, we include those analysis, a balanced sample of counties. It's robust to using the individual level data. And also, if we were like, there are some counties uh, where we only targeted migrants or Native Americans, and the way WIC operates in those populations could be different. So if we drop those counties, it's not driven by them. So yeah, now to conclude, yeah, so in this paper, we examine the effects of WIC on birth outcomes, and we see that after adding new rollout data, the effects of WIC on birth weight and low birth weight, they remain important. Our effects are larger than our predecessor paper, and also we see effects at different parts of the distribution. Also, we see effects that are larger in magnitudes for Black mothers. And as I was saying, we think that the explanation could be a combination of higher eligibility, worse baseline outcomes, and higher participation. Yeah, the results are robust to using new methods. And using a back of the envelope calculation, we see that our findings show that we reduce these overall disparities between Black and whites by around 5%. But yeah, thank you.
Thank you, Maria
Thank you.
Fernanda. People call you like this, Maria Fernanda?
They call
Oh,
me Maria or they call me Mafe because it's a like
ah, Mafe. Okay.
yeah,
Okay.
I have
Okay.
different names. So
Okay. Thank you very much. Oh, very, very interesting work. Very good.
yeah, no, I think I like your idea of trying to maybe look at the role of inequality,
Uh,
uh,
do you think
maybe
it's
in
possible to
education.
look for income inequality also or something? I don't know if,
I think I think maybe it's gonna be like maybe back in the 70s we could find and we need pre-programmed data. So maybe it's education. But
mm,
Racheri has done a lot of work on inequality and maybe he has some proxies of county income
okay,
inequality. So yeah, that I will look for yeah, either education or income inequality proxy, whether we can find
mm,
something back in the 70s.
okay, okay. I will open for questions. Is there any questions?
Uh, Hello, everyone. Hi, Maria.
Hello.
Congratulations for your papers. Really interesting.
Oh,
I have two quick questions. The
mhm,
first, if you also look for miscarriage in these places that receive the program, and pretty much in line what Lorena said, maybe uh, if I don't know if I missed something, but the
mhm.
week programs is like cash transfer to women, or just like
It's a
uh,
food package.
as a food pack.
Yeah.
Okay,
Mhm, mhm,
but if you also can look for any other cash and transfers program to these
mhm,
counties, the share of any other kind of program to
mhm,
assist poor women
mhm,
or something like that.
mhm, mhm,
Because I don't
mhm,
know if you it is really in line with the poverty or the share of populations that they're eligible because of the income
mhm.
threshold. I don't know if something is happening beyond the WIC program.
Yeah, so yeah, we the miscarriage part at that in the so we need that we couldn't get data on miscarriage because it was not collected in in the birth certificates. The thing we tried is we also look at death records and we look at neonatal mortality and infant mortality, but we didn't find any effects. Uh, any effects on that. But yeah, miscarriage it's an important outcome that but we don't have data on that, or we also don't have data on maternal mortality. That could be another important outcome to explore. And then yeah, we it's like the when we explore the place-based factors, we did use the state eligibility to the one of the main cash transfer programs that is the AFDC, and we it was not really playing a role, but yeah, that's a good question. If in places where families have more encounters with the poverty, with the safety net, there may be different effects of the program. That's a good point. Thank you, Antonio.
Any more questions?
As I was saying before at the beginning, yeah, I came across this paper. I imagine you guys know, I don't know him. I know his work, but I don't know him personally. But like Rudy Rocha, yeah, he did this paper, but is the one that I found was in 2021 about the saudade de familia, the
Saúde,
family.
saúde da família.
Yeah, and he found sizable effects on mortality, on prenatal care. Yeah, maybe I will see if I can email him. It will be nice to see if he's still working on that because you have a lot of you have really good data like birth outcomes as well and other outcomes across the life cycle. So it's interesting. And it's a
No,
very like one of the first programs of that kind in developing countries. So it's really
Yes,
interesting.
it's a very, very good, very important program here. Uh, I can stop uh, the
Okay.
the to record, and then we can talk more about. Okay. Thank you, everyone. See
Thank
you
you.
next year. Thank you, Maria, for being
Thank you.
here.
Thank you. Thank you
Okay.
so much. And yeah, thanks for the invitation. And yeah, I am now following you guys on Twitter so I can see your webinars. It's really interesting. I saw that you guys did a conference a couple of months
Yes.
ago. Cool.
Yes.
And you do it every year?
Yes.
Okay.
This year was the fifth time.
Yeah. Okay.
Yes.
Okay. Great. Great.
The
Great.
fifth meeting that we organized because GFA we began the group in 2019.
Okay. Right. Yeah. Okay. Great. No, it's a great. So you were one of the founding members of Jaffa?
Yes.
Okay.
Yes.
Great. No, congratulations for creating this platform for women in Latin America. Thank you, Lorena and Anna. Thank you so much.
No,
Great work. Thank you very much. I
Thank you.
will send you an mail about some questions related, but like really,
Okay. Yeah, very nice to meet you and hope to keep in touch. Thank you so
yeah,
much.
yeah, yeah. Let's keep in touch.
Yeah. Thank you.
we from this meeting, 30% of the panelists were from Latin America.
Yeah. Yeah. So, okay, that's super interesting.
Yes, it's good.
Yeah, and it's good that like doing more work in gender economics. Yeah, I want to do more work in Latin America, so I'm trying to to do. Yeah, I want to do more work.
Oh, yes, we have a very good uh, data set, especially public data set, especially regarding health
Okay,
outcomes.
okay, okay.